oxygen at home, we might have to put in a couple base units so that they get through the month, because we don't want to deliver them more than once a month because of the reimbursement problems that we have. So very limited supply. Can only deliver so many gas cylinders to patients' homes, right? Because there's safety involved with that. When we first took over a contract, this was many, many years ago, we took over a contract from another company, and it was a VA contract. And we went in the home to deliver our equipment, and we had a veteran, this is record, we had a veteran that had 126 e-cylinders in his home. Tell me, how safe is that? He had an unending supply, but tell me, how safe is that? So, also in the hospital, you have 100% gas source, 99.9% pure oxygen. In the home, we don't. You know, we have 90 to 95. If we have concentrators that make their own oxygen, some deliver a little bit less than 90, but the newer models all are around 90, 95%. But still therapeutic. In the hospital, you're testing patients at rest or doing 6-minute walks to see if they qualify for oxygen. Maybe. Some departments do, some don't. In the home, we're not testing. We know they qualify once they get to the home. We're testing oxygen during daily activity to make sure the oxygen device meets their needs. And if they're on continuous flow, we typically don't have a respiratory therapist going in because that matches what the prescription is coming from the hospital. But if they are on conserving devices, then best practice is to send a respiratory therapist into the home to monitor them. So what's our number one challenge in home care? Can anybody guess? For oxygen therapy? Let's just guess.
How about reimbursement?
That's a good one.
Reimbursement.
Reimbursement's a good one. These are all good ones. Compliance. So compliance. They're non-compliant. And why? There's many reasons, but why are they non-compliant? Well, you know, I like this quote that I heard at a conference way back in 2009 from Bart Shelley, pulmonologist. He said, would you use a drug that prolongs your life, didn't hurt to take it, well tolerated, costs little, it improved your exercise, mental function, heart function, and respiratory function? So why don't we use it? Why don't patients use it? If I look at that, I think I should probably be on it. If it's going to improve my exercise, my heart function, my mental function, why aren't they on it? Why don't they want to use it? Well, vanity. So patients don't want other people to know they're sick, okay? I think we see more and more patients out and about now with oxygen on, but years ago you never saw that. We used to have a patient that would, and we still get these occasionally, would not let our drivers pull in her driveway because it was a truck that talked about home medical supplies. And so when we delivered, we had to deliver 2 streets down. Not 2 streets down, 2 blocks down. Oh. So it's a real thing, because when you take a pill, you don't know you're sick. People around you don't know you're sick. But if you have a nasal cannula in your nose, they know you have problems. Okay? So that's one. They feel like they've lost their independence. They don't have the ability to just go out of the home, get in the car, and go away for 8 hours or spend the night somewhere without putting extra equipment in their car, carrying something around that might weigh anywhere from 5 to 10 pounds, or pull something behind them. So they believe that they've lost their independence. And I think the advent of portable oxygen concentrators has lessened this some, but we got to remember with portable oxygen concentrators, there are still a lot of limitations, and we'll get into that in detail here in a minute. Expense. It used to be it was free, basically, but now there are copays. So patients do have copays, and if they don't have a secondary, then they're responsible for that copay. There are high deductibles. Most of these people meet those deductibles early on, and they don't have a big expense, but you know, for this population, sometimes $25, $30 is too much because they're on a fixed income. They have no perception that they're short of breath. Their short of breath has decreased. So we all know, as respiratory therapists, that we want them to wear the oxygen because it improves their respiratory function, heart function. But really, do many of them feel a difference? No, but we know their heart feels better. We know all their organs feel better. But patients don't feel any different. So their shortness of breath is still there. So why am I on oxygen? limits their lifestyle, which I talked a little bit when they lose their independence, because maybe they were a traveler that travels, 3 or 4 times a month. Or maybe they have a separate home and the insurance will only pay for one device. And they want to go there just as much. So it really limits what their lifestyle used to be. And the weight. So we all know every patient wants something that, as Joe stated early on, goes to 20 liters per minute, but they also want it to weigh 2 pounds. And they want it to last days, okay? So the weight is an issue for a lot of these people. So even our lightest portable concentrators that weigh 5 pounds is still heavy for some of these patients, especially when you get into the elderly and the frail population. So this is, I stole this from Patrick Dune. He had published this in Respiratory Care a while back. But the primary objective to oxygenating patients is really across the continuum. We don't want to just qualify them at rest. We want to see, are they oxygenating appropriately at all levels? So when they're resting, are they maintaining oxygen saturation? When they're doing activities, so I mentioned activities of daily living. When they use some of these portable devices that have pulse modes on them, then we want to check them. How are they doing them when they walk to the mailbox, or when they walk up and down stairs, or when they reach to the cupboard? Okay, are their saturations maintaining with the setting that we have them on? When they sleep, okay, are they doing okay when they sleep? Some doctors will order nocturnal pulse oximetry to see how they're doing at sleep. And what about when we go in an airplane? Okay, we all know what altitudes do to our blood level, saturations, right? We all think that they may drop a little bit. I always think, do you remember Luke Hoffman?
Oh, yeah.
Luke Hoffman. I went to Vegas, we were in the same plane for an ARC conference. And he says to me, did you ever check your oxygen level on a plane? I said, no, but nobody carried oximeters with them back then. That was a long time ago. No, Luke Hoffman had a pulse oximeter in his bag. So he gets it out, and I put it on. And we were at high altitude, and my saturation was 90%. So, and it normally is 98, 99. So what do you think it does to our COPD patients in the air? Okay? So when we talk about portable oxygen concentrators, when we have those patients on the edge of that clinical capability of that portable concentrator, what do we think happens when they go in the air? Their saturation that was maintaining at 88 is probably a little lower than that, okay? But in most of these cases, the physicians say it's temporary, you're only in the air for a few, maybe an hour or so, so they'll say bump the concentrator up a setting. Well, the people that are on the edge of that concentrator setting really can't do that, okay? But we gotta understand that. So challenge number 2, somebody mentioned it as the first one. Challenge number 2, reimbursement, okay? Lots of rules to follow. So meeting the qualifications. Wouldn't you think if you had a diagnosis of COPD and you had a saturation of 80%, you would qualify for COPD, or qualify for oxygen? We had a claim rejected. Now that meets the criteria, but we didn't have face-to-face documentation from the physician that the patient required oxygen, and Medicare pulled that claim. So we had to go back and pull documentation from pulmonary functions. It depends what auditor you get. So even though I say these are the qualifications, it depends who the auditor is that's auditing your documentation. So I always go by Medicare because Medicare guidelines are the hardest to follow, and that's what most payers will follow, is Medicare guidelines. And I won't get into a lot of detail on this, but just give you the basics of what's required. So it's covered for continuous use if the patient has a chronic cardiopulmonary diagnosis. So I have here, diagnosis cannot be acute. So if they're in the emergency room, if they have acute exacerbation of COPD and the doctor didn't write before discharge that it was chronic COPD, it's not covered. Now, a caveat to that is CMS changes to policy. If anyone heard Joe earlier say CMS is finally feeling some sympathy for the HME industry, they have proposed, in a document, I don't know when this will go in effect, we're hoping 2022, but they changed the policy to include acute conditions. So if the patient is in the emergency room and they need discharge, you can give them oxygen. So we don't know all the details behind this yet, but that is one of the proposals. The ABG has to be performed, or pulse oximetry has to be done by a qualified provider. So a DME company is not a qualified provider, so they have to be qualified prior to them going into the home. Testing has to be done within 2 days prior to discharge. Okay? Documentation of other therapies tried before oxygen therapy. So the way we would meet that challenge was we'd get medication profiles, because if they were on breathing medications, we get progress notes, history and physical. But CMS also added to the policy, hopefully for next year, that will eliminate this. So we don't need to have other methods tried and failed. And I really think this was all a result of COVID, because COVID is acute, they present acutely, they don't want to get them out of the hospitals if they can. They're sending them home with pulse oximeters to monitor their own oxygen. They're sending them home with saturations meeting criteria of 92 and 93%, because patients are normally at 98 and they're dropping to 92 with COVID. So what we're seeing in our area, they're giving them finger pulse oximeters to go home with, and they're monitoring they're giving them oxygen, and they're monitoring it, the patients themselves. So I think that'll help when CMS, officially, right now with COVID, you don't really need any qualifications. COVID is kind of that caveat that if you have COVID and you need oxygen, it doesn't matter. We don't need testing. We don't need anything. Okay? So qualifying tests, ABG or pulse oximetry. If both are done on the same day, then you have to have the ABG. Okay? Except that we don't see ABGs too much anymore. They usually do the pulse ox a couple days before they discharge. Acceptable oximetry results, rest and awake, that's considered a pulse, that's a spot check. If they drop below 88%, less than or equal to 88%, they'll qualify. But maybe they're fine at rest. So they want an exercise, a 6-minute walk test. You have to have 3 tests documented. At rest, with the oxygen showing that it's normal. Then you have to exercise them, and off oxygen showing desaturation. And then you have to exercise them on oxygen, showing improvement in that test result. So, we tell people if you're in the doctor's office and they're just sitting there and they don't desaturate, but they desaturate walking from the front room to their room, and they desaturate when they sit down, that counts. That's not exercise. That's daily activity. That's considered rest, even though they walked from the hallway. So really, 6-minute exercise test is what they talk about in here. Really, can you do it in a home? Can you do it in most doctor's offices? Some have treadmills, but typically we see our patients going into the hospitals to have these walks done. And then sleep. If a patient has an OSA diagnosis, a sleep study must be performed and show desaturation while using the PAP. So if a patient has OSA, I think somebody mentioned this earlier, we can send them home. We used to be able to send them home with oxygen. How well did it do with obstructions? But if maybe they had some hypopneas, it worked a little bit. But now Medicare and other payers are saying, nope, you got to send them to the sleep lab, you got to put them on CPAP, you got to eliminate the apneas or show a decrease, and then if they still show desaturation, we'll give them oxygen. Okay? So that was a big change for our industry a few years back. So qualifying test results fall into 3 groups. Group 1, those are those patients that are less than or equal to 88% SAT or a blood gas less than 55. We usually use saturations. We don't see blood gases too often. That decrease in PO2 greater than 10 millimeters of mercury, I think I have worked for this company and home care companies for 30 plus years, and I've never seen it. So, but it's in their guidelines. You see a PaO2 less than 55 or SpO2 less than 88% with exercise, they would get the portable only. Well, we could very rarely see that, because most companies will build a stationary with a portable, because some of these new devices, you need the stationary to fill the portables. And then they have to see the doctor within 90 days for recertification of that oxygen. Group 2, this is that population that's in between. So their saturations, maybe 89%, rest, exercise, sleep. They don't hit the 88%, but they have diagnosis of congestive heart failure, they have pulmonary hypertension or hypersemia. Those patients would qualify, but it's a limited 3 months, and then they have to get requalified again. And in group 3, why they even have this listed is non-covered. Okay, so what are some of the challenges? Well, obviously the decreasing reimbursement doesn't allow for any extra services. So we talked earlier how respiratory therapists used to go out every month, and then every quarter, and then every year, and then non-existent. So that is the problem. And you know, when we were being paid a lot of money for oxygen, shame on those companies that didn't provide respiratory therapists at the time, because we were making enough money to give this support to these patients. But we did it for free. So we kind of shot ourselves in the foot, because now they still expect a lot of these services for free, but the reimbursement is so low, we can't afford to do it. Okay? When you go from $600 a month for a lifetime of oxygen to $75 a month for only 36 months, and you still have to take care of that patient, it's very difficult to do. So you have limited suppliers also doing full line of oxygen modalities. So there's a lot of HME providers out there that maybe only provide concentrators and home fills, or may not provide liquid oxygen, or only provide portable oxygen concentrators. Okay? So, you know, that is difficult, and, you know, it varies across the country. And, you know, in our area, we do have a couple providers that still provide all modalities, us being one. But I know there's parts of rural areas in across the country that they don't, and they don't have the ability for patients that need higher flows. The 36-month cap has really put a damper on us. These written order prior to delivery, well, yeah, we always got a prescription, but these written order prior to deliveries has certain elements that have to be in that prescription before we deliver, okay? Co-pays, high deductibles, and then, of course, our favorite thing is our audits. Challenge number 3. Anybody think? I'll give you this one, because everybody's ready for lunch and, huh? I know, but I'll give it to you. The equipment limitations. Okay, we talked a little bit about this. So we do have equipment limitations in the home. And if you heard my last lecture, I did talk a little bit about this. But, you know, again, when we look at the differences between the hospital and the home, we have, you know, a controlled environment in the hospital. We have 100% oxygen supply in the hospital. It's low risk for compliance because guess what? When you go in, you put the cannula on them and they don't take it off till they leave, usually. I lived through the day where they took it off with smoke in the hospitals. So, and the equipment, continuous flow standard versus intermittent pulse, or is the standard in the home for portability. So when you look at our options, you think, wow, those are endless. But you know, every HME company can't carry all these. You know, we're not like a used car dealer. We are a company that will choose based on the company's protocols. So, you know, we look at our company, we look at high-end clinical protocols to make sure they meet our needs of the patients. And I will tell you from a fact, us, we don't go by the cheapest one out there. We go the one that's most clinically effective. And I can tell you not every HME company is in the same arena, so there's variability in us all over the place. So I'll just go over this briefly for those of you that don't know these. There's 4 types of oxygen systems that we use in the home. Your standard gas cylinders, okay? We're limited though because we can't keep that many in the homes and keep them safe, you know, like the guy that had 126 cylinders. We can't do that, you know, so we limit what the patients can have. Our limit for our patients is maximum of 12 because we can give them 2 containers that hold it and they can keep 12 in their home. We don't go any more than that. But everybody's different. There's no best practice out there, so everybody's different. That's the problem with home care. There's no standards out there anywhere for us to follow. Yes, Joint Commission gives us standards, but they're general. They don't tell us how many. We just have to do it safely. And then we decide as a company what we do. The next one is the home fill system. And I know Joe talked about this, but this is a stationary concentrator. This particular picture is a home fill. And it actually, you connect it with a tube, and it'll actually fill cylinders on top of that device that's on the top. Okay, so it automatically fills cylinders. It's the method that was developed, and again, it was quite unique when it came out. It covered a lot of our expenses for this 36-month cap, where we still had to take care of the patient between those 2 years. This is a non-delivery method, so the patient can be independent. The patient can take care of themselves. That's great, right? Well, it is. But clinically, it's not always the best because it takes an hour and 45 minutes to fill some of these cylinders. So if your patients don't have good time management skills where, okay, I'm going out tomorrow to the doctor, I need to fill my tanks, well, we know what happens. Not always, but most of them go to get their tank the next day, and guess what? It's empty, okay? So we really need to provide definitely some backup to these patients, just some regular gas cylinders that don't fill from the home fill. just for those scenarios, because as a home care provider, you can't be everything to everybody. So if they call and say, I don't have a tank to go to the hospital, I can't get there in time for your doctor's appointment. Okay, so we really teach these patients to be independent, and they have to make sure that they have their backup ready for when they need it. The next one is liquid oxygen. So liquid oxygen used to be the Cadillac of oxygen. It was stored easily. You could store a lot of oxygen easily. The portables were nice. They were 4.5 pounds. They would last 10 hours. But the cost of this was not in the equipment or the oxygen itself. The cost is in the delivery. So when you're delivering these patients, these base tanks that you see up there, the tall ones, they're like a keg. They look like a beer keg, and they weigh about 200 pounds. So what you have to do is either you milk can them, where you take full ones and exchange, I see everybody shaking their heads, full ones, and exchange it for the empty one. Or we have trucks that have big tanks inside the trucks. We have to follow all kinds of DOT regulations. We go to the patient's home, so we fill it from our liquid tank in the office into the truck, and then we go to the patient's home, bring their base tank down, and fill it curbside, and then take it back. So it's hard on our drivers, it's hard on the service techs, because they weigh 200 pounds, and if no one's ever been to Pittsburgh, you have stairs that go straight up in some of these older homes in the city of Pittsburgh. So you're looking at lots of steps, 200 pounds of oxygen, and it's really hard on your drivers. It's hard on your delivery because you have to maintain these big trucks. You have to maintain certain regulations. So you will see, and we get paid the same as we do a concentrator and home fill. So we get paid $75 to do that. And between the 2 years where we don't get paid anything, we do get a little bit to cover that delivery. But I can tell you it only covers about 1/8 of that delivery. Okay? So that is why most H&E companies has gotten out of liquid. Okay? We still provide liquid oxygen for certain patient populations. That patient population is the high liter foot patient, the pulmonary fibrosis patient. Because clinically, what I believe is we should do what's right for our patients. Do I believe a 2-liter COPD patient needs liquid oxygen? No. You know, we got portable concentrators, no. Do I think an 8-liter pulmonary fibrosis patient that is active needs that? Absolutely. If not, they're carrying E-cylinders, and how many are they putting in the car of those? We didn't talk about that. Okay? So liquid does have its place. It's just a shame that, you know, we had to, all of our industry really had to do away with it. We tried to get a patient, she was traveling, and she was traveling to Florida, of all places. You would think Florida is a travel place, right, for winter, and we could not find anyone to fill her liquid down there. Not one provider in in Florida couldn't find it. So now the patient who is on high liter flows has to travel with cylinders in the car, and when she gets there, we line her up with a provider that'll be bringing her cylinders a lot. Guess who has to pay for that? We do. Okay? The other provider can't bill. We have to provide that. So we get, the company down there bills us. So not only do we have to provide oxygen every month at $75, if they decide to travel, we also have to pay for that. Okay? So, then came the advent of POCs, which is great, because now we have patients that they want to fly, they don't have to drive, they're great. That was probably the best thing that came into our industry, with limitations that people have to understand. So, when we look at trying to get the length of our portable concentrators and our cylinders, we put on them what we call a conserving device, or a built-in conserving device, which is in our portable concentrators. And what that means is they just deliver oxygen when you breathe in. Okay, well, it makes sense. Why do you need to run continuous flow, right? Because you're wasting oxygen when I exhale. So it would make sense that if you had a 2-liter patient and you put them on a setting of 2 on a portable concentrator, well, that should be fine, right? Well, keep that in mind, because I'm going to go over the variabilities that we have in portable concentrators. So it's not as easy as that, okay? But what happens is we put conserving devices on to conserve. Well, what happens if we conserve too much? Patients aren't getting what they need, okay? So just keep that in mind. We want to monitor these patients to saturate. We don't want to conserve to desaturate, okay? So what these systems do is they extend the life of their portable system, but they deliver a volume. So they deliver in mLs or cc's, a puff of oxygen when they breathe in. Sometimes that oxygen is delivered at the beginning of the inspiratory cycle, sometimes it's delivered in the middle of the inspiratory cycle, and some of it's delivered at the end of the inspiratory cycle during dead space. So that's one variability we see in these. So volume is delivered faster. It's just like your ventilators. Some are delivered real fast, and they get there real fast, but yet there's still time for oxygenation to occur, and some deliver very, very slow if it gets to the end of dead space. So they all deliver differently. They're triggered differently, okay? So they all have a sensitivity. Some will trigger very easily, some won't trigger at all, or some will have missed breaths, okay? So the settings on the dials of the POC is just a guide. So if they come out on 2 liters per minute, depending on what portable concentrator the company has, they may have to adjust that patient up to 3 or 4. That doesn't mean they need 3 or 4 liters continuous oxygen. That just means on the portable concentrator, they're on a setting of 3 or 4 to meet that need, okay? So multiple devices are available, but no 2 are created equal. They're all different. So a conserving device also can be mechanical or pneumatic, or electronic. The electronic ones seem to be more sensitive to patients' needs. So they usually run by batteries. You think, oh God, now the patient's going to change batteries, and then they're going to call us out to change batteries. Well, sometimes they do, but we tell them we can change our own batteries. But some of the conserving devices, we use the Smart Dose, and see, Joe's not in here, and I'm giving him all these plugs. But the Smart Dose is a conserving device that will automatically titrate based on breath rates. So those units do take a battery, and they have batteries, though, that will last a year. So the batteries last a year. And they're just standard batteries, but it's the way the mechanism works that they're a year. So they don't, it's not every month they have to change batteries, they're a year, okay? So with that, pulse doses can be 3 different ways. You have a fixed bolus. So that means at every breath, whoever made that portable concentrator or made that conserving device, the manufacturer goes to the FDA and says, I want this approved. My device will deliver, I'm just picking numbers, 24 mLs at a setting of 2, and I'll guarantee that up to a breath rate of 24. And they pick that breath rate. So what happens with that breath rate goes to 30 when the patient walks to the mailbox. Okay? It stops. It doesn't meet their needs. It doesn't deliver oxygen. So that's why, I don't know if anyone works in pulmonary rehab in here. Anybody work in pulmonary rehab? How many times do you find your patients come in and they're short of breath and desaturated when they walk in the door? All the time. Okay? Because those units just can't meet their needs all the time. Now, these patients may recover very quickly. They may not desaturate that low, but we've seen patients desaturate pretty low on some of the conserving devices that are out there. Minute volume, and this is usually your portable oxygen concentrators. Okay, what this is they have a set volume that those portable oxygen concentrators can make. Because think about it, an oxygen concentrator makes its own oxygen by pulling in the room air and storing the oxygen. That's a real high-level explanation. But if you have a small portable concentrator that weighs 5 pounds versus one that weighs 25 pounds, what do you think the reservoir difference is? A lot, because the little one can only hold so much. So it's based on a minute volume, and most of them make around 1,000 mLs. Some make up around 1,200 mLs per minute, but you won't see too much after that for the small units. Now the bigger units, they make more. Okay, but it's a set minute volume. So if you have a patient who's breathing really fast, they're going to get really small boluses of oxygen. If you have a patient that's breathing really slow, you're going to get nice big volumes of oxygen. I'm not saying any one's better than the other, really. You just have to match them to your patient's needs. And then there's audible adjusting ones out there. And it adjusts volumes versus breath rate. So for example, what the conserving device I mentioned is a smart dose. What it does is it automatically adjusts breath rates based on the baseline of that patient. So if the patient is breathing 20 breaths per minute and the unit picks that up, when a patient walks to the mailbox, they're now up to 32 breaths per minute. That unit, every 4 breaths, it'll increase the bolus size. So the first 4 above that baseline, it'll increase the bolus to maybe, I'm just picking numbers, 56. And then if their breath rate goes 8 above that baseline, it may go to 110. But as soon as that patient comes back down to rest, guess what? It comes back down to below 7. Okay? They have that in a portable concentrator now. So that technology is also built into portable concentrators. The only problem is remember, a portable oxygen concentrator can still only make so much oxygen. Okay, so there's still limitations. If you put that conserving device on a tank, your tank runs out, you just replace it. If you're on a portable oxygen concentrator, it just can only make so much oxygen. It's just not there. Okay? The goal also is to deliver oxygen during that first 70% phase of the inspiratory cycle, because we don't want to deliver oxygen. Everyone remember this from school? Anyone remember this? This is that old diagram. Us boomers in here, okay? But we want to deliver it during the first 70% phase of the inspiratory cycle. We don't want to deliver oxygen during dead space. What's the point of that if we're not oxygenating at that point? So that's where a lot of these devices will vary. So they have built-in conserving devices, the pulse mode only available in the small units. So if a patient needs continuous flow and can't tolerate, you cannot get them in a small unit. Okay? Oh, how do I go back? Hello. I don't need that. I'm going to talk about it anyway. So understanding their variability is key. The flow rates change. The flow rates are really fast on some. The flow rates are really slow on others. The bolus size, or the bolus rate too. So the size of the bolus, it can vary. I've tested many of these because I have this little device that I can put on any POC, and I can mimic breaths, and I can see how much delivery they give, and it'll range anywhere from 12 cc's to 28 to 32 mLs per bolus size. So it varies. So everyone is different, okay? The sensitivity, some are very sensitive, others aren't. The purity of the gas. There are ones out there now that will give you alarm states that if the purity of the gas drops below, I don't know what the number is, 80, 85%, 90, then it tells you, okay, it turns yellow, says you better, we're getting close to the end of your life. There's sieve beds, if anybody wants to know. That's usually the problem. Then if it's red, it doesn't work anymore. They call us. Okay? So there are ones out there that now have that. The battery life and expense. So, you know, these devices, the batteries are extremely expensive. So you'll see most home care companies giving them one battery. But they have the ability that they can private pay for a second battery. But our costs as an industry on those batteries are upwards of $200 and $300 on some of them. So expensive mode, and a lot of patients don't want to pay that because that's our cost, so we always mark it up a little bit. It's very expensive for these patients. And when you add battery, what do you add? Weight. So a lot of these concentrators have extended batteries on them, but we typically don't do that because they add weight. So the marketing tactics are to the consumer, not to the patient. So how many times have you seen an order or a message during The Price is Right, Lifetime movies that advertise for portable concentrators or CPAP supplies or diabetic supplies or whatever it may be? So is that really looking? Patients don't understand these clinical differences. They have no idea. So if we don't educate our patients, because a lot of them are purchasing them online, you know, some of the units that are out there online, I'm not saying they're bad units because we use some of them, but I'm saying that those patients should be checked with their pulse oximeter to see if that unit's going to meet their needs. Not to mention, if they purchase these online, the disease state never stays the same, right? So if they need 2 today, they might need 4 2 months from now, and they've bought this very expensive unit. So what happens? Where does it go? eBay, okay? Or Craigslist. So, online purchasing, eBay. I know I can't see this, and I didn't memorize this, but this eBay, this one says, hold on, which one, can you see it from up there? The flow rates, I think it's on there, 3 to 9 liters per minute on this little 5-pound device. I know, here's the best, I know this. You can get anywhere from 30 to 90% purity. Do you think patients understand that? They have no idea what that means. And you tell me what small portable concentrator goes to 9 liters per minute. Okay? Here's another one. Okay? This one. This one was about the same thing, but look, it was only 117 polymers. That is a bargain. If you're a patient that needs oxygen and you see that, oh wait, this one's the one that says it's 60 to 90% plus or minus 30%. And it weighs, it's only $117, it weighs 5 pounds. That's exactly what I need as a patient, right? Okay, so then you can go to Walmart and you can purchase any of these. Now, most of the time they'll tell you need a script. Okay, I can get a script, right? eBay. And this was the best. When I was presenting this, I had to pull this up for another lecture a few years back. Craigslist. I pulled one of our units up that was for sale. Right there's Craigslist, and right there's our label. So they were selling one of our sequels, and I couldn't trace this because I had no idea who it is. I don't know the serial number. But they were selling one of ours. So, what do you think is going to happen to those patients that buy them online? They now can't use them anymore, and they paid a lot for them. Where are they going? Now, eBay is pretty good right now as far as domestically selling them. And I got in a little battle back and forth with eBay that they should not be selling these because it's medicated. Oxygen is a drug. So they did pull them out of the States, but they said they had no control internationally. So these ones that you're seeing on eBay is international. Craigslist, God only knows what you find. We found lots of our equipment on Craigslist in Pittsburgh. Okay? So, again, fact or fiction, POC advertising targets the patient's clinical needs. Bottom line savings, best value, cheap prices, huge selections, sole purpose is to conserve oxygen. Doesn't matter what you do clinically, if your stat stays up, but the sole purpose is to conserve that oxygen. Maximum conservation lasts longer. So, I'm not saying that the POCs out there are bad. I'm just saying that as a DME company, we have to know what we provide. Best practices is to check those patients on a pulse oximeter and make sure they're saturating during their activities of daily living. So, I'll use this example, and I used to put pictures of concentrators up there, but I don't anymore. But, if you were a patient, would you want A or B? A, it weighs 4.6 pounds, it lasts 4 hours, and it's carried by a nice purse strap. Or would you like one that weighs 10 pounds, it's 3.5-hour battery, and it has a cart you gotta pull behind you? Most people want A. Most people want A. But when you look at the production of the oxygen, A will maximally produce oxygen about 840 mLs per minute, and there are higher ones out there now. There are ones that go 1,000. But on A, if I have a breath rate of 15, I'm going to get about 56 mLs per breath. And as soon as my breath rate goes up to 25, I'm only going to get 33 mLs per breath. Now it doesn't seem, does that mean anything? Yes, because most of these patients desaturate when they come into pulmonary rehab. Okay? Maximum oxygen production on B is 2,000 mLs. It's 10 pounds, but it's in a cart. Okay? But look what you get at breath rate of 15, you get 130 mLs, 133 mLs. And if you increase your breath rate to 25, you get 88 mLs per breath. So, big difference. Doesn't mean A won't work for patients. It absolutely will. But know your patient and know their limitations and know their activity level. So, patients are choosing for the wrong reason because, like I said earlier, they want it to look nice. We all want a purse, right? It's got a nice black strap or brown strap, and I think you could probably buy ones that have colors on them if you wanted. The size, they want it to weigh 2 pounds and they want it to last 2 weeks. The longer it lasts, the better, and the lighter it is. And they want their battery to last a long time. prescription, not what they're going to do when their disease state changes. So this was just a study by a Hallway and all, I don't know if I pronounced that right, but he took small subject group, 13 patients with COPD. They walked on the treadmill on room air, or 2 liters, or a bolus of oxygen from one of the 4 most popular conserving devices. And they did pulse oximetry, they checked their oxygen saturations, nasal ventilation, they were monitored at rest and activity. What they found, when they were on 2 liters of rest, they all maintained saturations greater than 90%. So that's continuous flow of 2 liters. The minute they start walking them, saturations decreased with all of the conserving devices that they had on, and they did this with 4 of the most popular. So what they found was the breath-by-breath rate varied greatly. Regular activation of the device happened, but they all desaturated, and it was very inconsistent bolus delivery, and one was no better than room air. So you might as well just put the patient on room air, and they saturated the same as if you put them on something else. So you can see all that, just a small snapshot of how variable these devices can be, okay? So when you're talking about if there could be a readmission or the patient's not saturating, think of it, is it their disease or is it their device? If the oxygen bolus doesn't meet their needs, then it's not working for them during activity or exertion, then it could be the device, okay? It's not an exacerbation. There's limitations on these portable concentrators because they have very limited reservoirs. And there's poor synchronization between triggering. So sometimes they'll trigger when the patient takes a breath in, sometimes they won't, and sometimes they'll trigger whenever they go to exhale. So some of they just vary, okay? Again, doesn't matter one's any better than the other. So the equipment limitations, and I did touch on this a little bit earlier, but I'll just repeat myself. So flows greater than 15, we can't do because the oxygen tubing in the home doesn't go higher than 15. Okay, that's a maximum of high flow cannulas and tubing. Portable systems are extremely limited for patients that are on greater than or equal to 4 liters continuous. The small portables for sure, but some of the bigger portable concentrators that weigh 15, 20 pounds that they pull behind them, most of those will definitely saturate them. But do you think patients want a 20-pound portable concentrator on wheels? They don't. They want something that they can carry, but unfortunately, the technology is just not there. So high flow systems are really difficult to achieve, and we talked about that too with the trach masks. Typically the highest we can go is around 45%. There is technology out there that we could provide high flow in the home. Airvo, my Airvo. I mean, everybody who's used these things in the hospital, there's no reimbursement for these for home care. And like Joe said earlier, and the DMRC really doesn't want to look at giving us a code. And they've been fighting this battle for at least probably 8 years, and we still haven't seen any movement on it. So we talked about the uncontrollable environment as well earlier. We've got lots of safety hazards that become barriers for us. We have deplorable conditions, no electricity, limited electricity. We have a big Amish population where we live. So, you know, we end up that's another reason why we're trying to provide liquid oxygen. Because if not, we're going to be putting cylinders there and we're going to have to drive out there every month, and that really depletes any kind of reimbursement profits that we may get, okay? Criteria for placing, we have to look at different things. So we as a company, and I know others do it different, but we as a company, we don't really have a cookie cutter approach. Not everybody gets set up on the same thing. We do take into account liter flow, ambulation, dexterity. So maybe you have a high liter flow patient that has pulmonary fibrosis, they need 8 liters, they need liquid. But they may not be able to fill that liquid device because it takes, I can tell you, as being a short woman, it's hard for me to do it because I have to stand on my tiptoes to push it down to get it to engage. So if you have somebody that has limited dexterity, height, it's difficult. They just may not physically be able to do some of these systems. How often do they travel? If they're travelers and they go out and about all the time, they need something different than stationary concentrator and e-cylinders. Okay? What's your home environment look like? And the safety. So how do we accomplish this? So we actually have a position called respiratory support specialists that are longtime drivers that's been with us for years doing equipment, that after we do the delivery, they go to the home within a 5-day period to go through, re-educate the patients, because we know patients only remember about 30% of what you tell them. So they re-educate, They go over safety. They ask these questions. So do you travel a lot? Do you go and about, yeah, I have a camp, but I'm not going to get there. So he brings that information back, and that's when we will tailor some of the modalities for that patient. It's not an oxygen conversation if we don't talk about smoking with oxygen. So we all know smoking can be a deadly combination. And for anybody that's in home care in here, I don't know about you, but the minute I'm watching the news and I see that there's a fire and they mention the word smoking, oh my God, my computer's coming out and I'm looking up to see if that address fits any of our patients. Because if it does, I'm turning in a sentinel event to the Joint Commission, and I got to prove that we educated that patient. Okay? So smoking in the home is a serious concern, especially since we know that more and more people are being discharged to home on oxygen. So with that said, we've got to do a really good job at educating these patients. But we talked about non-compliance earlier. Well, we get a lot of patients that are non-compliant with this. Okay? But this was something that was published, I think it was 2009, 19, yeah. So this was published, and basically what this was the impact of home oxygen fires. So the yellow highlighted area, if you see that, and at the bottom, there was 164 deaths. There were 71 serious injuries, okay? That's a lot when you think about it. And that's death. That doesn't include minor injuries. We've got 119 over there, 31 without any injuries. But, you know, what's even sad is, I know there's only one there, but one death to a firefighter because a patient was smoking with oxygen. Should not happen. Okay? 145 of the users died, and 63 had serious injuries. You know, those numbers, I know if they did this again, it probably would be higher. Okay? So, you know, placing an order for long-term oxygen therapy, you know, some of the questions you have to ask, you know, was testing done to qualify the patient or to saturate the patient? And I know you're going to say most of the time it's done to saturate the patient, qualify the patient, but when they get to the home, that's when we want to saturate the patient. Okay? Has the patient been started or tested at rest and activity? Most of the time, if you're doing that in the hospital, you're not. But when they get into the home or pulmonary rehab, you do need to do that. You need to do what they're doing. Now, is the patient going to be as strenuous in pulmonary rehab as they are at home? Not always, because you're working them a little bit more in pulmonary rehab. But we still want to make sure when they get up into their covers or they go into the bathroom to get a shower that they're still saturating. Does the patient require low flow or high flow? Okay, if they require high flow, we got to have that little team meeting and talk about what we can do to get that patient home. Was information communicated? I'm going to say communicated one time. 7. Oh, she counted 7. Was the information communicated? Are there any known safety issues? Is the patient bedbound? If the patient's bedbound, why am I delivering a portable oxygen concentrator? I can't tell you how many orders we get for portable oxygen concentrators from physicians, and the patients are bedbound. You know, that doesn't even make sense. But it happens. Is the patient ambulatory? Will complications arise? Is there an issue? You know, any limiting factors to this patient? So extremely, extremely important to communicate. So with that said, with our patients, all patients are different. All patients are unique. All home care companies are different. Okay, some have unique things. Some have good, some have bad. Some are just trying to survive, quite frankly. So if you know, we're stretched thin, but we still have to make the right decision for our patients. So they're all unique. All oxygen delivery systems are unique, but we have to tailor what our company pulls in as equipment and tailor that to those patients. Okay? Patients need to be assessed for the utilization of oxygen. So if I have a patient on liquid oxygen, just because they've had it before we got rid of liquid oxygen and they're on 2 liters, and they've never been filled, I shouldn't be billing the insurance company. I need to pick that up. Okay? So those are things that we have to make sure that we're following and monitoring. But one thing I just want to clarify, I just want to make sure, and I know I've said this before, but this portable oxygen concentrators are a great advent to patients. But just so we know the right one is placed on your patient. Any questions? No questions?
Thank you.
Thank you.
we're going to do something different for respiratory therapists this year that we've done every year for sleep, and that is a panel discussion. So we're gathering our panel members right now. They're going to be here. Kim is one of them. Joe Awarski, Roger's one of them. Okay.
I do have a question.
Oh,
I'm interested.
you're late. It's over.
Oh,
Done.
sorry.
I
Sorry.
can't answer your question.
Related to COVID, how has your organization had to change your infection control procedures if you're accepting COVID patients?
That's a very good question.
Here,
So,
here.
I'm usually free to help.
Yeah, you are.
So with COVID patients, we have a lot of COVID patients coming home. Some patients don't want us in their home. They want us to do the setup on the porch, which goes against everything we've learned because we've got to do a home environment assessment. So if they insist, we will set it up on the porch and we document patient refuses to let us in the home. But what we try to do is do it within the home. Our drivers wear full PPE, so we have they've been fitted with N100s and N95 masks. They also have the shields. They also have the gowns and the booties. They've been trained and taught how to don and doff. So we've got drivers that had to learn, just like we did, in infection prevention measures. So it's a lot of training, quite frankly. We had some service technicians that quit because they didn't want to deal with it. We had some that they do it every time because they don't believe it's real. So it just varies. It varies, but we did have to do a lot of education.
Thank you.
You're welcome. Any other questions?
Stay tuned. I know Zach and Joe are on their way, so stay with us.